Hello and welcome to this webinar. This webinar being presented to you by the International Pharmaceutical Federation and in association with the Western Pacific Pharmaceutical Forum, webinar titled Understanding and Managing Headaches in the Community, Therapeutic Approaches and Advances in the Western Pacific Region. My name is John Jackson, and it's my great pleasure as President of the Western Pacific Pharmaceutical Forum to be your moderator today. We have 4 speakers that I will introduce to you individually shortly. But before I do, just a few words of introduction. Headache is a very common condition that we're all familiar with. 70% of all of us suffer a headache at least once per year. There are a number of causes and types of headaches, and they range, of course, from headaches that are of short duration, self-limiting, and able to be treated with non-prescription medicines, to headaches that are signs of life-threatening conditions. And pharmacists have a very important role in differential diagnosis, working out the likely nature of the headache, and, where appropriate, assisting people with the treatment of their headaches. So, we've got 4 speakers, as I said, to speak to us on this topic today, with a focus on headache in the Western Pacific region and options for pharmacists in treating those headaches in the community. A couple of points about this webinar, a couple of housekeeping points. The webinar is being recorded and it's being live streamed to you via YouTube. This will be able to be seen at a later stage on www.events.fip.org, along with all of the other webinars that FIP has produced and delivered over the recent time. If you have questions, and I'd hope you do have questions for our speakers today, please put them in the question box at the bottom of your screen. And as usual, you're most welcome to provide feedback on webinars@fip.org. If you are not already, I would strongly recommend you become a member of FIP, a member of this wonderful global family of pharmacists. Moving on to the next slide, what I do need to do is recognise the support of Sanofi in enabling Professor Goetzman to speak with us today. And I do need to recognise that wonderful support which enables us to bring this kind of event to you. This is the program for today. As I said, 4 speakers, Professor Peter Goetzman and Professor Takaya Kumamoto. Both of their presentations are pre-recorded, and then speaking to you live will be Dr. Luminita Constantine and Dr. Dan Malone. After each speaker, any questions you have, please put them in the chat and we will come in the question box, and we'll come to those and at the end of the presentations in the Q&A session. The next slide shows you the learning objectives of today's webinar to provide insights on the therapeutic approaches and advances used in the management of headaches, to understand the role of non-prescription medicines as a tool in headache self-care, and identifying the role of the pharmacist in supporting the self-care of headache through a regional lens. So let's move on then to an introduction of Professor Peter Goetzman. Professor Goetzman will be speaking about understanding 21st century headaches and their impact on patient wellbeing and quality of life. Professor Goetzman is Professor of Neurology at King's College London and a Director of the NIHR Wellcome Trust Clinical Research Facility at King's College Hospital. He's a Professor of Neurology at the Department of Neurology, University of California, Los Angeles, and an honorary consultant neurologist at the Hospital for Sick Children, Great Ormond Street, London. And I'd like to play for you Professor Goetzman's presentation.
Hello, my name is Peter Goetzman. I'd like to thank the International Pharmaceutical Federation for asking me to speak at these series of meetings about 21st century headache and the way headache is impacting well-being and quality of life. I'm a neurologist and I'm interested in headache disorders. One of the realizations of some work I've been doing with colleagues in the last year and a half to 2 years is that a large number of people, perhaps the largest group of people with headache disorders, don't actually see doctors. And to be simple, we've referred to this as non-doctor treated headache. So on the left, if you look at the population of people who actually seek medical care, who are treated by doctors, about 10% only end up with a neurologist. About 20% of patients end up with a primary care doctor. However, at least 50% of patients with a primary headache disorder self-treat. This is the non-doctor population. It varies a little bit between countries, and I've been working with colleagues, as you can see, from the UK, France, Germany, Brazil, Japan, and Australia. Broadly speaking, very clearly, the largest group do not see doctors. In particular, tension type headache is overwhelmingly treated without consulting a physician. Where does the pharmacist fit in all of this? Well, migraine itself, commonest disabling form of headache, has been stable at the very top, in the top 10 of the leading causes of years lost disability over the last 30 years. What is notable is an increase in the analgesic market and an increase in medication overuse headache, as you can see, from the 23rd most common to the 20th most common disorder in 2015. Pharmacists have a really important role here in providing advice to patients on the use of over-the-counter medicines for pain management, particularly in headache, and advice about the misuse or overuse of those medicines. We can help patients understand what's happening by helping them collect their own information, helping them keep a record, and using analgesics optimally. Now, from real-world data we've collected using the Migraine Buddy app, it's clear that most patients with headache, or indeed with migraine, will have up to 4 attacks per month. As you see, the vast majority will have less than 2 or between 2 and 4, and the very smaller group, which come to see headache specialists and neurologists, are those that have many more attacks a month. Certainly, our clinics are full of patients with more than 10 attacks per month. Now, patients report in their diaries missed work, social activity, and family time. They report being slower in what they do, slowed up at work. They report difficulties with sleep and difficulties with concentration, impacts in their daily life. For the management of tension type headache and for migraine, it's important to be aware of what's available, and particularly for tension type headache, given most of the management is going to be done outside the physician sphere. We know from the evidence, nice report, review that Ashina and colleagues published this year, that aspirin and acetaminophen, in parentheses paracetamol, or caffeine combinations or non-steroidal anti-inflammatories are the top options for the treatment of an attack of tension type headache. For prevention, lifestyle modification, acupuncture has a role, and tricyclics such as amitriptyline, other medicines, mirtazapine, venlafaxine, as preventives if they need to go on and see a physician. You'll see the distribution is rather similar throughout the world, with about 85%, 86% of patients all over using a non-steroidal, about 70% paracetamol, acetaminophen, about 50% aspirin, with a little bit of regional variation. Remarkably, in the 21st century, of those with a primary headache disorder, 50% self-treat, and only 20% see a primary care physician. Remember that migraine is the most common disabling primary headache disorder. Lifestyle things are important. Sleep disturbance facilitates headache and often can be associated with cognitive dysfunction. We're obtaining robust, real-world evidence from e-diaries, population-based. Most of the patients in these diaries have less than 4 attacks a month, and thus primary headache disorders can often be well managed by pharmacists. There's an enormous amount of good to be done. I'd encourage you all to do it. Thank you.
I would like to thank Dr. Goetzman for that introductory presentation and remind you that if you do have any questions, please put them in the Q&A box at the bottom of your screen. If you have questions very specifically for Dr. Goetzman, we can pass those on to him and the question will be answered and the response provided to you. I'd like now to move on to our next speaker. Our next speaker is Professor Takaya Kumamoto, and his presentation is titled Therapeutic Approaches and Advancements in Headache Management. As you can see from his bio, Professor Kumamoto is professor in the Department of Synthetic Organic Chemistry at the Graduate School of Biomedical and Health Sciences at Hiroshima University in Japan. He was a professor in the Department of Pharmacy at the Mushimoto University prior to that, and he has been chair of the FIP Board of Pharmaceutical Sciences Special Interest Group on Drug Design and Discovery, and is currently chair of the FIP Special Interest Group on New Medicines. Professor Kumamoto became an FIP Fellow in 2017, and I'd like to now play for you Dr. Kumamoto's presentation on therapeutic approaches and advancements in headache management.
Hello everyone, I am Takaya Kumamoto from FIP BPS New Medicine SIG and Hiroshima University, Japan. Today, I will talk about therapeutic approaches and advancement in headache management. According to the International Classification of the Headache Disorder, migraine and the tension type headache, a main part of the 21st century headache, were recognized into primary headaches, which caused by their headaches by themselves. Other headaches associated with other factors, such as injury, vascular or non-vascular disorder, infections, other medicines and its withdrawal, are categorized into the secondary headaches. Usually, the secondary headaches become an urgent case, and if you can observe the patient with a sudden and usual headaches or a high fever or change of their mind states, immediate consultation of the doctor will be recommended. Here lists the medicine used for the headaches, including prescribed medicines. The list of some information in this talk were collected from the guideline of the chronic headaches published by Japanese Society of Neurology and Japanese Headache Society, and translated in English and published on the web. For prevention use, the calcium channel blockers, beta blockers, S inhibitor, ARB, anti-epilepsy, and antidepressant are used. For the acute therapy, NSAIDs, acetaminophen, ergotamine, and antiemetics are used. Triptans are also used for the acute therapy. The chemical structure is related to the serotonin, and its mode of action was at first assumed to cover the shortage of serotonin. However, recent research suggests that the triptan works to binding its receptor on the trigeminal nerve to control the release of the neuropeptide. Safety of the triptans was suspected for the patient with cardiovascular risk factors because of the vasoconstriction activity. Towards this issue, recently new type of the selective serotonin 1F receptor agonist were approved. As shown in chemical structure, it was different structure from those of serotonin or tryptans. And so the selectivity is expected on its vasoconstrictions. Regarding the neuropeptide named CGRP, it was reported to be released from trigeminal nerve and to bind CGRP receptors on the brain blood vessels to induce the neurologic inflammatory developing to the migraine. Towards this issue, CGRP itself and its receptor become target of the drug discovery, and their monoclonal antibody which binds to CGRP itself and the CGRP receptor were developed to inhibit the functions of CGRP, and they are recently approved for the acute and prevention use. Small molecular CGRP receptor antagonists, so-called GEPANs, were also approved for the acute therapy. For the treatment of the tension-type headache, NSAIDs, caffeine, antidepressant, and muscle relaxants are used. For OTC, single drugs of the acetaminophen, NSAIDs such as aspirin like ibuprofen are used. Loxaprophen is approved as OTC in Japan. As a combination products, aspirin, acetaminophen, or both combined with caffeine or sedative drugs are used. As the type, combination of isopropyl antipyrin, acetaminophen, anhydrous caffeine, and isopropyl acetylurea is also used in Japan. In several countries such as UK and Germany, some triptans were approved as OTC. The problem with OTC access to triptan is overuse. Pharmacists should warn and advise the patient to use a triptan on less than 10 days per month. For natural herbal medicines, Kampo medicines are approved as OTC in Japan. Some of them would be used for the headache, for example, Kakkonto, Goshirto, and Goreisan. For the preparation of this talk, I will discuss with a community pharmacist in the case of the headache patient visit pharmacy. One pharmacist pointed out the headaches are more common in women, so it is recommended to think about the balance of the hormone change for their scheduling, because headaches may vary depending on their menstrual cycle. Also recommended to pay attention to the weather change because its change in the atmospheric pressure can affect to their headaches. Other pharmacists pointed out the patients who are buying ibuprofen OTC even though NSAIDs has been prescribed, and the other patient prescribed NSAIDs from multiple medical institutions. Most of them seems not aware of the relationship between headache and their lifestyle, for example, as possible trigger for the headaches like lights, smells, smoke, sleep, alcohol, and exercise. Pharmacists can support such a patient by asking their lifestyle and the timing and the strength of the headache attack to improve the lifestyle and reduce the number of the medications. And it is also pointed out if they are taking the medicine more than 10 days per month, medicine overuse headache would be suspected. As an example of the short-term interview of the headaches, screening the questionnaire forms are useful, such as 3-question headache screening, ID migraine screening, Midas instruments, HIT6, and HAUT index. It is valuable to collect the information with a limited number of the questions. And it is not might be a special method, but the other method can be used for the interview form, consisting with the following 7 questions with location, quality and quantity, timing and setting, factor, associated manifestations, and additionally lifestyle and drug history. For example, a patient has tightened pain at the back of the head, which continued from 1 year before and occurred once per month, and this time from today's afternoon, and getting long-term working PC strength and the evening, and weakened by the rest. In this case, it can be from the tension type headache. As the other patient claims severe headaches in head, catching a cold 3 days ago and getting worse from the last night. And it was with a simple training of the head and cough associated with high fever, chill, and nausea. In this case, headaches by the infection should be suspected. Headache diary can support the patient for the recording their headache attacks, symptoms, and the treatment. It can help doctor to make a diagnosis, and pharmacists can use for the advice. Patients themselves can recognize triggers or warning signs, assess whether their acute and preventive medication is working, and show any patterns of attack. Regarding to the weather-associated headaches, what weather can be triggers such as change of the humidity and temperature, storms, extremely dry conditions, and dust environments. For the management of these kinds of headaches, research like a smartphone application to inform the weather forecast can be applicable to avoid such headaches in advance. As a possible medications, analgesics can be used, and compound medicines can be used as OTC in Japan, for example, with Goetzman. As take-home messages, several prescribed medicines and OTC are effective for the treatment, acute or prevention for the migraine and tension type headache. Approval of recently developed triptan derivative and CGRP-related medicines increase the choice of the treatment of the headaches. Pharmacists can support a patient to reflect their lifestyle relating to the headache, which can lead to the improvement of their lifestyle and reduction of the medications. Utilization of headache diary and the digital tool for the weather-associated headaches will be also effective to manage the headache. Medicine overuse headaches can be suspected when the patient takes headache medication over 10 days for 3 months. Thank you for your kind attention.
And I'd like to thank Professor Kumamoto for his presentation. It is very interesting to see the similarities and the differences in the therapeutic options that we have available to us in our different countries. And I'd like to remind you that if you have any particular questions for Professor Kumamoto, if you can put them in the Q&A, and if they cannot be answered on this webinar program, we will refer them to Professor Kumamoto and get him to answer them and provide those responses to you at a later time. So let us move on now to our next presentation. And our next speaker is Dr. Luminita Constantine. And her presentation is titled Regional Approaches to Headache Self-Care. So we're now starting to focus very much in our Western Pacific region and looking how things might vary in our region and in particular in the self-care area. Dr. Constantine holds a bachelor's degree as a medical doctor from Romania and a certificate in medicine development from the UK. She has over 25 years of experience in the pharmaceutical industry, working in multinational, multicultural companies, cross-functionally and globally. She is a medical affairs professional at Sanofi, promoting safer and appropriate drug use and enhancing healthcare professionals' ability to make appropriate decisions in partnership with patients and customers, and bringing the voice of the patient into business innovation. I'd like to invite Dr. Constantine to give her presentation.
Thank you, John. And hello, good morning, good evening, good afternoon to everybody. I'm so honored to be here today. And we will talk about the regional approaches to headache self-care and for the Western Pacific region. Please go to the next slide. Thank you. As it was presented previously, worldwide, 50% of the people with headache are estimated to be primarily self-treating without contact with health professionals. For Western Pacific regions, the figures are quite similar with the global one. What about the prevalence of the headache disorders? Next slide, please. At the turn of the century, most of the world's population lived in regions where prevalence of the headache was unknown and its impact was poorly understood. Lifting the Burden, a non-profit organization in official relation with World Health Organization, was working to scale this unknown burden. Based on a program of population-based studies performed in countries all over the regions, they have demonstrated a high prevalence of headache disorders, including migraine, tension-type headache, medication overuse headache, and their association with impaired quality of life, substantial loss of productivity, high economic cost in every country surveyed. For Western Pacific region, only one population-based study was standardized with standardized methodology was in the panel. And we are talking here about China, with the lowest range of data compared with other regions, only 24%, similar for TTH, tension-type headache, and migraine. The disparity between China and the other countries is more likely, given its size, to have a genetic rather than cultural or environmental basis. In all these countries, from the Asian region, as in Europe, women were more likely than men to report migraine and similarly headache on more than 15 days per month. We will go to the next slide. And as might be expected, headache disorders were generally associated with impaired quality of life across all countries, and also an impact on productivity from paid work and from household work. Societal impact was consequently very high. The burden of indirect cost, attributable mostly to lost productivity, was equated to 1.9 loss in GDP in China. Despite the differences in prevalences, the socioeconomic impact of headaches disorder was similar for the Western Pacific, such as Southeastern Asia region represented by India and Nepal. And I'm talking here about 1.7 up to 1.9. Next slide, please. And we will talk about 21st century headache. What is 21st century headache? It's an expert consensus paper published this year. Experts agreed on the observation that headache, now occurring earlier in life, it's attributed to modern life and contributing factors, mostly associated with changing lifestyle, such as stress, bad posture, diet, lack of physical activity, climatic changes, and atmospheric temperature. And also, on top of this, the COVID pandemic, which increased the screen time, which increased the stress and social isolation, which increased also to all sorts of inadaptabilities of our human being at the new life situation. And this has had a negative impact. 21st century headache has a negative impact on concentration, attention, problem solving, reasoning, perception, coordination, motivation. Also, it's conducted to a situation where we do not see the thing clearly. Aside of pain and of headache and a blurred mind, we can say that there is an impaired mental clarity in association with reduction in social interaction, absence from work, absenteeism, presenteeism, present at work but not being able to work, reduced productivity, and lifestyle compromise. What about the treatments? We are addressing 21st century headache. Next slide, please. As it was presented, the main class of drugs to treat headache disorders are analgesic, antiemetics, specific anti-migraine drugs, and prophylactic medications. Management of tension type headache starts, of course, as it was presented, with patients' education and management of known triggers, and symptomatic treatment is required for mild to severe headaches when headaches affects function. For the Western Pacific region, we do see that the main, I will focus on the analgesic used in self-medication. NSAIDs are by far the most preferred analgesic drugs, followed by paracetamol and followed by aspirin. And you have here the figures compared with the global tendencies as they have been presented in the video from Professor Goetzman. Next slide, please. What about the headache medication and the COVID pandemic? Beside the obvious concern about limitation of the virus spread and providing the best possible care to the infected patients, a concomitant concern has arisen in view of a possible link between the use of certain drugs, such as renin-angiotensin system inhibitors and ibuprofen, and an increased risk of COVID-19 infection. This study shared the concern in relation to headache treatment and conclude that based on the current evidences, there is no reason to abandon treatment of headache patients with RAS inhibitors or ibuprofen. And there is no convincing evidence that either RAS blockers or ibuprofen facilitate or worsen SARS-CoV-2 infection in any type of patients, including headache patients. This is a work in progress, and all the time we are assessing and following in companies in direct relation with health authorities to understand what's happening and how it's evolving, and to get much more knowledge how this molecule, we know them for tens of years. I'm talking here about NSAIDs, which are known from 60 years, paracetamol, something similar, and aspirin, how they are interacting in this new area, in this new time. Next slide, please. What about the self-management, COVID, and e-commerce? We've noticed that Q1 2020 drug sales boosted by COVID pandemic. And also this high level of growth, it was expected to be short-lived due to consumer stockpiling of OTC, and they wanted to prepare for pandemic. Also, pandemic provide boost to e-commerce. Growth was driven by higher dose of NSAIDs, new ingredient combination, fast-acting products, smaller pack size, and combinations. Although e-commerce of medicinal products has many benefits for patients and pharmaceutical industry, it remains still a concern for regulatory authorities worldwide, but not only for them, because in some cases, medication overuse, as it was presented, and medication overuse headache, because we are focusing on the headache, can be a side effect which is not controlled. Next slide, please. In order to conclude my presentation, primary headache disorder can often be well managed by the pharmacist, as Professor Goetzman has presented. And pharmacists play an integral role in pain management by assisting patients and prescribers with the selection of over-the-counter analgesic. A pharmacist may be the last healthcare professional a patient or a consumer sees before utilizing an OTC drug. Patients often ask pharmacists for advice when selecting an OTC analgesic. Therefore, it is important for pharmacists to know what question to ask patients, and you know them already, and you are using, if time allows, in your practices. And like this, to ask the patient to help ensure that informed recommendations are made. The following key consideration can help you to support each and any patient in selecting and safely using an appropriate OTC analgesic. And by assessing patients' characteristic and medical history, by explaining the recommendation and discuss the expectation for the pain relief, reviewing the dosage of recommended product, and ensuring that the patients understand the recommendation and it was individualized. So it is very important that at the end, all of us, we are contributing and we are working for the good management and best management of headache sufferers. And we do have to be mindful that we have a world of generic drugs, but no generic patients. And every patient requires specific consideration and an individualized recommendation. I'm quoting a pharmacist, Professor Robert Barkin, and for 21st century headache, this advice is still standing strong. So thank you very much. I'm giving back to John.
Thank you very, very much, Luminita. That's a wonderful presentation. It helps us understand a lot more the role of the pharmacist in treating headaches. So moving on, if you are a pharmacist and you are present in your pharmacy, there is likely to be people coming in to see you because they have headaches. What are your treatment options for them? What should you do? Our next speaker, Dr. Dan Malone, is going to look at the pharmacist's role in supporting self-care in headaches. Dan is the Director of Pharmacy Education at Monash University in Melbourne, Australia, and has responsibility for the education of approximately 900 undergraduate pharmacy students. He's a registered pharmacist himself, and he works part-time in the community pharmacy, and he actually teaches on this topic of the treatment of headache. So he comes with a lot of experience and relevance. Dan has won an Australian Government Office of Learning and Teaching citation for outstanding contributions to student learning, as well as numerous university and faculty teaching awards. While Dan's PhD focused around animal models, aspects of psychosis and behavioural effects of cannabinoids, over the last 5 years, he has focused on exploring ways to improve the education of pharmacy students, in particular regarding assessment methods, improving cultural capability and professionalism. So Dan, I'd like to hand over to you and hear your presentation on the pharmacist's role in supporting self-care in headaches. Thank you, Dan.
Many thanks for the kind introduction, John, and thank you for SFIP for the opportunity to present today. I'd like to start just by outlining what I'm going to be talking about, and I'll try very much not to double up on what has already previously been discussed by the excellent presentations you've already seen. But essentially, I'll be talking a bit about tension headaches and these other headache types from the perspective, as John said, in terms of managing in the community pharmacy, looking at differential diagnoses, potential red flags for referral, as well as other issues that haven't been mentioned so far, as well as some other alternative treatment options. Next slide, please. So to start with tension headaches, I just thought I'd, again, not try to already talk about what's already been discussed, but briefly mention that as was discussed, there are some people that do have genetic predispositions to tension headaches, which is to be importantly considered. But the fact that the reason I put this picture, this diagram here on, is to highlight the fact that peripheral sensitization can occur, and therefore there is a major role to play in terms of community pharmacists to recommend non-medicine treatments such as massage and other treatments that can decrease that sensitization effects. As indicated on the left, pharmacists do play a critical role, a crucial role in terms of ascertaining the cause. And from a differential diagnosis perspective, it's important to establish whether a person has a true tension headache or whether it's due to, for example, if they've been working outside all day on a hot day and not drinking enough water, is it just due to dehydration? Are there other medicines they're taking, or is it due to some other condition? Next slide, please. So that's why non-medicine treatment is always first line. Professor Kumamoto mentioned already about headache diaries, then I think they're really important, but also thinking about the sensitization, relaxation training, even an ice pack on the neck or head, massage can also help. And I'd also make the point that with NSAIDs and paracetamol that have already been discussed by our presenters, fast-acting NSAIDs are really important here to get to the site of action quickly, not only for tension headaches, but also for migraine, so that you have a fast onset of action, which can hopefully mean that there's less likelihood of a person needing to take a follow-up dose of medicine a few hours later. Also, I'll just touch on the fact that opioids in Australia, we used to have combination opioids, so codeine and paracetamol, codeine and ibuprofen products in particular, that many people took for headaches, and that did lead to an increased incidence of medication overuse headache, which has been previously discussed. So fortunately, I think now in Australia, but sometimes, in Australia, opioids aren't now available over the counter for headaches, but they are in some countries. So I would caution you not to recommend these products because of the propensity for addiction as well as for leading to medication overuse headache. And caffeine's been mentioned previously by a speaker, so I won't dwell on that, except to say that there is good evidence for its efficacy when combined with acetaminophen or paracetamol or NSAIDs. Next slide, please. And I'd like to talk just a bit about some other commonly used natural medicines for headache. In particular, so taking from the start, we've mentioned caffeine already. Capsicum, particularly for cluster headache, which I'll mention in a moment, does have some evidence in a nasal spray form, which I'd never had it, but I'd imagine that would be quite disconcerting given its propensity for producing a really strong effect in terms of, anyway. Feverfew is something that can potentially reduce the severity of pain associated with migraines, and I'll talk about migraines in a bit, but the evidence is mixed. There's a lack of evidence for fish oil. Interestingly, people that who have migraine are statistically more likely to be magnesium deficient than the general population, indicating that perhaps people should be eating more foods with magnesium in it if they suffer from migraine, that is, if they're shown to be deficient. Rubbing peppermint oil onto the temples, there is some evidence for that to be benefit in terms of relieving headache. The other natural agents on this slide are all more so used for preventing rather than treating, but peppermint oil may have there's some evidence to suggest that it may be of assistance in terms of treating headache. Willow bark and yerba mate, there's less evidence for either of those. And I'll also just make the point that the placebo effect in any clinical study with regard to headache medicines is generally quite high. And this study, Kim Hansen et al. Mentioned that relative to no treatment, the placebo accounted for more than 50% of the drug effect, indicating that it's important to provide information, and perhaps the ritual pill-taking process have a role to play in terms of alleviation of headache. Next slide, please. I won't talk too much about cluster headache because it's not very common. And really the pharmacist's role here is, if a person does have a first episode cluster headache, detecting that that is a cluster headache is important. And so, as indicated in this picture, it's severe pain around one eye with possibly other symptoms such as teary eye or also inflammation around the eye. And it's thought to be, women have described it as being more painful than giving birth. Now, I've never given birth myself, but I've seen it happen 3 times and it looks very painful to me. So it must be very painful. It does require an immediate referral to a physician. And if someone was unfortunate enough to have a cluster headache when they were in your pharmacy, I would be ringing an ambulance immediately. As I mentioned before, there is some evidence to suggest that capsaicin nasal spray may be of some benefit for cluster headaches. And of course, oxygen is a natural therapy, and that's also thought to be of some benefit. Next slide, please. We've already heard from other speakers about the importance of keeping a diary and ascertaining trigger factors. And so from a migraine headache perspective, it's really important to do that. And I thought this slide, this picture here, was a nice summary of all the potential trigger factors for migraines. So this tells us that it is really important for people to keep that diary and try and elucidate themselves what could possibly be triggering either a tension headache or a migraine. Something else which you do see commonly, which I've seen a lot in community pharmacies, people coming into a community pharmacy saying, oh, I've got a migraine. And then you ask them about their symptoms. They say, oh, it's this rough band across my head and, you know, it comes and goes and I'm feeling okay. And it's like, well, mate, that's not a migraine. It's a tension headache, or probably a headache caused by something else. So it is important to ascertain that the symptoms are that of a migraine. So that is it unilateral? Is it throbbing? Is it that you can't stay in bright light and sound you're really sensitive to sound? And so if they have these sorts of symptoms, then yes, it probably is a migraine, but it's important to establish that. Next slide, please. So for migraine, as for other headache types, it's really important to avoid trigger factors, as I've mentioned. Pharmacists have a role to play in terms of managing and providing that advice about what to do when they have a migraine. So going into a dark room, for example, and lying down. NSAIDs and paracetamol are first line. Interestingly, with migraine, there's good evidence to suggest that there's gastric stasis that occurs. That is, the stomach doesn't empty as quickly. And because of that, and also because of the fact that nausea is quite common during an attack, if a person takes oral analgesics later in an attack, they can be erratically absorbed, or a person can vomit them back up and may result in treatment failure, which is why it is important to take formulations early as possible. And as I said before, for tension headache, same applies for migraine, where a person really needs to take an appropriate dose, preferably on an empty stomach, so that that absorption is really quick. And that may mean that they have to take less of a follow-up dose later on. If a person's particularly nauseous, then antiemetics can be considered. And again, opioids should be avoided. Next slide, please. So this slide, adapted from the therapeutic guidelines, shows if a person came into a community pharmacy with any of these symptoms, then it is important to refer them to a physician as soon as possible. So a really sudden onset headache could be a subarachnoid hemorrhage, for example. If a person has any sort of neurological signs as well, such as weakness in the left arm or the right leg, then that might be a sign of some sort of more serious condition. Head trauma, then that could mean that it's a subdural hemorrhage, for example. If the frequency is changing, increasing over weeks to months, then that might be a sign of the same condition, a subdural hemorrhage, for example. And so any of these sorts of signs, then we would want to refer a person to a physician as soon as possible to ensure that they are properly assessed for another cause of that headache. Next slide, please. Just quickly, and as indicated before by a previous presenter, it is important to ascertain that it is a true headache. And if it's a sinus headache, then we want to ascertain that it's a sinus headache. So the pharmacist has a role here to play in terms of identifying that it's a sinus headache caused by congestion of the sinuses. And as you can see in this picture on the top left, it's really around the sinus area, obviously, that you'll get the pain. Because it's secondary to that pressure around the sinuses that exist, it's important to treat that sinus pressure or that build-up of inflammation in the sinuses rather than treating the headache directly. Pharmacists also have a role to play here in terms of referrals. So if a person has fever or severe pain or an infection of greater than 7 days, these are all signs that it might be a bacterial infection, and there may be other signs of bacterial infection too. And so that would require immediate referral to a physician for antibiotics. Next slide, please. So again, important to treat the underlying cause before the headache. There's a lot of products on the market in many countries that have just normal saline in them that either you make up yourself or a pre-made that can just flush out the sinuses and therefore potentially relieve the pressure. But oral analgesia does have a role to play, particularly in combination with a saline type product. There is some evidence to suggest that intranasal corticosteroids may be of benefit in sinus headaches, as can intranasal decongestants potentially, but that's controversial, and I don't have time to go into that. But next slide, please. In terms of medication overuse headaches, again, the previous talkers have talked about this already. I'll just again highlight that the pharmacist does have a major role in terms of detecting this. So if people are coming in often for analgesics for headache, it is important to do a proper diagnosis and determine how often they are using these agents and give them advice about potentially how to reduce their analgesic use, because of the fact that this downward spiral can occur when a person has chronic head pain, they use analgesics a lot, they may have a comorbidity such as a sleep disorder or anxiety or depression, which can then potentiate the use of analgesics and lead to this downward spiral occurring. Next slide, please. So best treatment is obviously prevention, but educating the patient about the propensity for medication overuse headache is really important. Looking at how to reduce the analgesic use is important. There's some evidence for abrupt withdrawal working okay, although that will then probably lead to a rebound headache, as well as other symptoms such as restlessness and irritability. So that may require withdrawal symptom management via a physician. And this picture that's shown here is from Headache Australia website. And on the top panel here, it shows each spike there is a headache or a migraine occurring. And then the green arrow in the middle is when a person starts taking an analgesic. And as you can see on the top panel, the level of headaches actually gets worse. Whereas if a person on the bottom panel is taking an analgesic for, say, a condition such as arthritis, it's not thought to lead to an increase in amount of headaches. I would make the point, though, as that reference at the bottom of the slide mentions, that a whole idea of medication overuse headache is actually a little bit controversial, in that there is a school of thought that suggests that frequent use of symptom-relieving headache medications should be viewed more neutrally, in that it may just be indicative of poorly controlled headache rather than the use of the analgesic causing further headaches. But I just thought I'd throw that open as being a counterpoint. But inevitably, the management is the same, that we do want people to reduce the use of analgesics as much as possible for headache. Next slide, please. So just to conclude, pharmacists do play a major role in ascertaining the cause and treatment of various headache types. That really the only role for cluster headache is to detect the first episode and refer. And to elicit trigger factors is important as well, and help the patient, the person work out what might be causing the headaches, particularly for migraine headaches and also for tension headaches. And to really offer that really good advice around how to best use their medicines to ensure that they are using them in the most appropriate way possible to reduce the acute headache, as well as to prevent the use of medication overuse headache. That's the end of my presentation. Thank you very much for attending and listening, and I'd be happy to answer any questions.
Yeah, thank you very, very much, Dan. Great presentation. And as Dan said, he's available to answer any questions. There are no questions in the Q&A box that I can see at the moment. There was one that we've referred on to Professor Kumamoto, but very open to questions being put in the box. And while you're thinking about it, let me ask Luminita and Dan a question about caffeine as a component of combination analgesics, because caffeine in itself has no analgesic efficacy. Caffeine has the issue of keeping people awake, and so timing of day becomes important. And sometimes there are additional substances added to combination products to counteract the effect of caffeine, such as a sedating antihistamine. So is caffeine really a suitable and appropriate additional product in combination analgesics? Luminita, would you like to make some comments on that?
I would love to do this, and you enter into my territory, let's say, because I'm focusing on combination, and I'm focusing right now on combination of ibuprofen and caffeine, paracetamol and caffeine. So you touch a big point. A Cochrane meta-analysis said that caffeine acts as a co-analgesic and helps somehow to push the analgesic to act better and faster. We have also parameters in terms of number needed to treat and risk ratios, which shows that there is a certain amount of analgesic, of caffeine, which can connect it to the drug, can help. So there are certain range and can help for better pain relief. So I think it's an interesting combination. It's all over the world, and we can allocate much more time locally, to understand each of us how this combination may act and can be a step forward. We don't need any new medication. We just have them. And to have them in a right combination and in a right association can be a step forward in pain management. Then it's to you.
I agree with you, Luminata, 100%. The evidence I've seen, most evidence shows that caffeine is able to increase the effect of other analgesic medicines. The combination with paracetamol is a good example of this. Personally, though, well, it's very individual specific, I suppose. So we do know that people are to varying degrees sensitive to caffeine. Myself, I could not have a combination caffeine product because I would be up all night. My wife, for example, she can have a cup of strong coffee before bed and sleep perfectly fine. And so for her, yes, if she had a headache, then it would be completely appropriate, but for me, it would not. So I think it's very much individual specific, but there is evidence to suggest that it certainly can boost the analgesic effect of paracetamol and such products.
Thank you, Dan and Luminita. We only have a minute or two left, but I have one more question that I'd like to ask you. Non-steroidal anti-inflammatory drugs have become the mainstay of analgesia in a lot of countries. Aspirin has reduced in relevance for good reason, but NSAIDs aren't without risk. I'm thinking, for example, their effect on renal function, fluid retention, potential cardiovascular risk. What's the role of the pharmacist in offering NSAIDs and warning people about these risks? Dan, how do you do that?
Oh, I think that's crucial, John. And considering particularly in Australia, the fact that ibuprofen, aspirin, these products are available in supermarkets where people get no advice from a pharmacist. And it's really important to ascertain whether a person has is on any other medicines that may interact with the NSAID, if they have had any history of gastric issues such as peptic ulcer, if they have any, as you mentioned, renal issues, then it's certainly not good to take NSAIDs for any condition. I would preface, I guess, by saying that with headaches, hopefully people aren't getting headaches too often, and therefore the less you take an NSAID, the less risk of adverse effects, admittedly. But if a person is taking NSAIDs a lot for headaches, if they're taking them potentially 15, 20 times a month, then that is an issue. Particularly if they do have any pre-existing illness that may mean that NSAID is not suitable for them. So I agree with you. It's crucial for the pharmacist to do a proper history taking to ensure that the NSAID is safe for the person.
Luminita, I'll give you the final option to comment on that.
No, thank you very much. I do not have any further thing to add. Just to know, it's not easy in the daily practice to put the right question in the right time when you have a line of patients needed to. So I think that each of us can do a sort of template, and really to observe the patient and really to put the right question. Only one question might be relevant in the case of, time constraints. And like this, maybe we make a step forward to our patients. So thank you very much.
Thank you. Thank you. Look, one thing I would like to suggest is a take-home message from today's webinar. Many people see pharmacists as a readily accessible healthcare professional who can handle a lot of simple, basic health problems. But of course, we do see people coming into pharmacies who have some of the symptoms you've heard today, which are of acute concern. They are signs of potentially major health issues. And as frontline health professionals, we have that opportunity to play an important role and refer on to other healthcare professionals, be it a doctor, be it an ambulance, be it a hospital. And I think our role in that acute care triage is not adequately recognised in the health system. But I'd like to thank our 4 speakers for the presentations today. It's been an incredibly informative program. I think the 4 presentations built to a wonderful focus. So Peter Goetzman, Takaya Kumamoto, Luminita Constantine, and Dan Malone, I would like to thank each of them. But I'd in particular also like to thank the crew at FIP for all their hard work in organising these. And in my final comments, I'd like to remind you that very soon we have World Pharmacists Day, 25th of September, the day when we can celebrate our role in healthcare. And there's some comments there about how you can create your presence on social media and promote the role of the pharmacist. This is the 11th year of World Pharmacists Day, and it's growing in its relevance. So I'd strongly recommend you get on board. There are a lot of other FIP offerings in these webinars. Just go to events.fip.org to see what's available. And as I said earlier, this one will be available there shortly. So thank you, everybody, for your attendance. I hope you've enjoyed and found incredibly useful the information that you've received today from our 4 wonderful speakers.